Congenital midline anomalies. Summer 2009. All of these anomalies occur prior to the 4th to 10th week of embryonic development. Many occur together. If you see one, look for another. Midline anomalies: cleft lip and palate, tracheoesophageal fistula. Congenital heart defects. Neural tube defects, spina bifida. Omphallocele and gastroschisis. Anorectal malformations. Exstrophy of the bladder. Omphallocele intra-abdominal contents herniate through umbilical cord. Fail to return to abdomen in 10th week of gestation. Intestines and liver. Protrusion covered by translucent membrane. 1. 25 5/1000ths live births, intestines only. Associated with other congenital abnormalities. Gastroschisis. Defect of the abdominal wall with herniation of abdominal viscera outside the abdominal cavity through defect to the side, usually the right, of the umbilicus. Small intestine and ascending colon. 1/10,000th live births. Care of child with omphallocele or gastroschisis. Cover sac or contents with sterile saline gauze and sterile plastic. Monitor vital signs, especially temperature. NPO with for maintenance of fluid and electrolyte status. Monitor for infection. Surgical correction, silo for gastroschisis. Attainment of bowel motility and function. Anorectal malformations. 1/4000th to 5000 live births, minor to major. Anal stenosis. Anal atresia. With or without clavesicular fistula. Medical management with dilations. Reconstructive surgery with or without a temporary ostomy. Anal stenosis can be managed with dilations using stainless steel dilators. Weekly visits to nurse-run clinic, QCN, or MD office. Size of dilator is gradually increased. The baby hates it. Mom needs lots of support to do it every day, and sometimes more frequently than daily. Anatresia, stool can pass out fistula to bladder if there is one. Sometimes there is a fistula to skin equals colocutaneous fistula, but clavesicular is more common. Stool is in urine. Risk for infection. 9 years. Child with anorectal malformation. Required 2-stage surgery, temporary colostomy. The remaining segment was so short that the colostomy was left in place until the reconstruction grew. She had 3 surgeries, although the takedown of the ostomy was fairly quick and simple. Continence can be achieved if there is enough sphincter. Goal is continence. If could not achieve continence, used to have permanent diverting colostomy. Now they too can have the Milanese procedure that will be discussed later in lecture. She was able to achieve continence, although later than normal, and is now 9 years old and very active and normal in every way. The bladder wall extrudes through the abdominal wall. Bladder exstrophy. The bladder wall extrudes through the abdominal wall. Many also have epispadias. P. 1630, exstrophy of the bladder. Treatment: surgical reconstruction. Usually done 24 to 48 hours after birth. Goals: bladder and abdominal wall closure. Preserve urinary function and continence. Creation of normal appearing genitalia. Improvement of sexual functioning. Everything on slide. Exstrophy of the bladder. Pre-op nursing care. Prevent infection and trauma to bladder. Post-operative nursing care. Care of the surgical site. Positioning, alignment. Neurovascular assessment of lower extremities. Monitor renal function. Promote comfort. Discharge teaching. Wound and pelvis have to be immobilized. Osteotomy to rotate innominate bones to close symphysis pubis. Ureterostomies done to divert urine to diaper or pouch. Epispadias repair at 1 to 2 years of age. In first stage, bladder is closed and innominate bone rotated. Internal and or external fixators used. Avoid abduction of legs. Bladder needs time to grow to accommodate normal amount of urine. Second stage, to repair bladder neck and reattach ureters. Bladder tissue is abnormal and has high incidence of developing malignancy. Start screening at about 20 years of age. Continence may not be achieved. May need ACE or diversion. Urologic surgical procedures. Vesicostomy. Ureterostomy. Mitrofanoff catheterizable stoma. Malone antegrade colonic enema stoma, MACE or ACE. Vesicostomy, bladder brought to abdominal wall and opened just above symphysis. Ureterostomy. Both ureters can be brought out together or separately. Mitrofanoff and MACE described shortly. Post-op nursing care of stoma skin protection. Care of stents, tubes, drains. Signs and symptoms of problems. Vesicostomy and ureterostomy, drain into diaper. Rarely do parent accept pouch unless it is needed to protect skin. Mitrofanoff and MACE equals child is discharged with a catheter in the stoma as well as stents. Spina bifida/myelomeningocele. Neurogenic bladder and bowel. High incidence of VUV, especially if spastic bladder. Increase incidence of PUV and UPJ obstruction. Early management is essential. Everything on slide. Emphasize that renal failure secondary to neurogenic bladder used to be the cause of early death of this population. Now their lifespan approaches that of normal adults. High incidence of posterior ureteral valves, PUV, make catheterization difficult even with a Coud-tip catheter. Ureteral pelvic junction obstruction cause stasis of urine above the stenotic opening. Incompetent UPJs cause vesicoureteral reflux, VUR. Stents are placed for UPJs until stenotic portion can be removed. Incompetent UPJs are reconstructed to prevent reflux. These defects can occur without spina bifida. Nursing interventions. Prevent damage to upper tracts. Clean intermittent catheterization. Vesicostomy or ureterostomies if grade 4 reflux. Prevent constipation. Prevent skin breakdown. Promote self-care. Everything on slide. Recurrent toots used to cause staghorn calculi that filled the kidney pelvis leading to renal failure. Constipation can cause stasis of urine as ureters cross constipated bowel leading to bladder which is in the pelvis. Self-care and self-concept are important for normal development. This lead to exploring a way to make intermittent catheterization easier than trying to reach the perineum in individuals with varying degrees of paralysis and trunk instability. It works so well that it is being used for many other diagnoses that require regular intermittent catheterization. The MACE was developed after the Mitrofanoff as a way to completely empty the colon periodically so that it is empty and therefore incontinence cannot occur. Next slides describe procedure, pre- and post-op care and teaching. Mitrofanoff appendiceal stoma. Creation of catheterizable channel from skin to bladder. Channel is created from reversed appendix that is attached to bladder that has usually been augmented, made bigger. End of appendix brought to skin has nipple valve created and is usually placed in the umbilicus. Everything on slide. Post-op care for Mitrofanoff. Stoma with stents and catheter protruding from it. Keep skin clean, dry and protected. Discharged home with stents and catheter in place. Teach care, prevention of infection, when to call, return visit. Everything on slide. Teaching for Mitrofanoff usually done as outpatient. Clean intermittent catheterization using long vinyl Coud-tipped catheter, usually a size 12. Must catheterize or will go into renal failure. Bladder neck is either closed or suspended to prevent leakage. Bladder must be catheterized regularly to prevent stasis, which is the primary reason these individuals develop OOTs. It is not frequent caths that cause frequent OOTs, it is stasis of urine that breaks down and become a perfect medium for bacterial growth. Melonantigrade colonic enema. Creation of catheterizable channel from ascending colon to skin of abdomen for purpose of giving colonic irrigation every other day. Renders the child bowel continent. Channel is fashioned from piece of small intestine and brought to skin in nipple valve. First used on children with incompetent anal sphincters, paralyzed open. Always have a smear of stool in their underwear. Gravity pushes it out as they walk or sit. Post-op care for MACE stoma with catheter protruding from it. Keep skin clean, dry and protected. Discharged home with catheter in place. Teach care, prevention of infection, when to call, return visit. A diverting colostomy was originally done to divert stool while stoma heals. I have heard that some surgeons have had success without it. I don't know any surgeon that does it without the colostomy. Teaching for MACE must irrigate every other day to maintain continence. Use mild enema solution. Maintain schedule for frequency. Allow time for evacuation. Most use saline to irrigate. Some who are very prone to constipation use a softening agent. It can take several hours to evacuate. Remember, the bowel is neurogenic, it doesn't work normally. They have to plan activities around the irrigation. Otherwise they will be incontinent. Nursing assessment: ask child where stomas are and which one is which. Allow child to do procedure as at home with usual ritual. Must be done even if child is ill with unrelated disorder. It is hard to identify where the stomas are. Scarred abdomen from other surgeries? Mitrofanov is usually hidden in the umbilicus. MACE is usually on the right side of the abdomen, but ask. If you don't know how to get the specimen, ask the child. He does it all the time. Child should be able to do his own cath by time he enters school. I've taught boys as young as 3 and girls as young as 5. Elizabeth is gorgeous. She was born in Mexico. Elizabeth is gorgeous. She was born in Mexico. We found her when her brother came to Shriners LA to have his club feet repaired. He was 3.5 and not potty trained. I'd taught my clinic assistant to ask about siblings and she told me that his 6-year-old sister wasn't potty trained either. We immediately put mom on a bus to go back and bring the sister back with her the next day. IVP revealed grade 4 VUR so bad that the kidney pelvis seemed to be continuous all the way to the bladder on one side and almost as bad on the other. She was immediately taken to surgery where a vesicostomy was performed before lunchtime. It took 3 months for her to reliable catheterize herself. Once she was reliable, we looked down the vesicostomy and she has continued to perform self-cath. Both she and her brother have lipomining ocelles that are skin covered. Eventually they both needed bladder augmentations and bladder neck reconstruction. They have moved to California because of all the medical care they required to get both of them bowel and bladder continent. She is now in nursing school.